Hello, Population Health Learning Collaborative. I'm George Dealy.
And I'm Julie Lamoureux from your sponsor, Dimensional Insight.
Dimensional Insight develops analytics applications for healthcare and other industries using our Diver Analytics platform products and technology. We've been widely recognized in independent, customer-focused research for our ability to help our customers drive health outcomes. We're excited to be part of the collaborative to share our knowledge and experience in the areas of measurement, information, and analytics, and how they can help guide population assessments as well as the implementation and management of strategies that flow from those assessments. Julie is our subject matter expert in clinical quality, population health, and all things statistical.
And George leads our DI Healthcare Analytics Development Team, which is working on population health applications and tackling other information challenges in the realm of health and healthcare. During the next 10 to 12 minutes, we'll be touching on 4 topics that lie at the intersection of population health and information. This is intended to stimulate your thinking and ideas around which topic you'd be interested in exploring further in future webinars.
The topics that we've selected are measures and measurement in populations, potential information sources for supporting those measurements, examples from the front lines, and the impact of emerging technologies. The clock is ticking, so let's get going. So Julie, you're the health statistics expert. What are some of the issues that we need to think about when we're assessing and measuring populations?
So, how to measure population health is evolving as we get access to more data. But not all data is created equal. A few aspects of data to consider are related to the framework of the triple aim, now evolving into the quadruple aim. It needs to have a holistic approach to the measurements. Improving population health should not be done at the detriment of the user's experience of care or the cost or the provider's experience. So some of the aspects to consider when you are measuring population health is the granularity of the data. Various data have various granularity. It's easier to decrease granularity than to wish for more details in the long run. So, for example, median income by zip code versus median income by census tract can make a difference between identifying pockets of poverty in your service area and missing it. Another aspect of measurement is the sensitivity to change. Populations can be described using many measurements, but ultimately, to assess improvement in population health, only measures that are sensitive to the improvement program will inform you on the effect of your program. Another aspect of the measurement is time and timeliness. So different health problems require more or less timely data. If you're trying to identify an outbreak, you don't have time to wait for mandatory reporting data analysis result. You need to possibly choose a potential proxy measure that is more timely, maybe less reliable, but at least you get a quicker idea of when an outbreak happens. On the other hand, if you're deploying a prevention program, you can use highly sensitive and highly reliable delayed data because your assessment of the program is not time sensitive. Then also there's an aspect of standard versus customized measures. You all know the standard measures that governmental agencies will work on and will deploy nationwide. Sometimes those measures are not very sensitive to your programs if you have very specific programs to improve your population health, and you have to opt for more customized measures. The downsides of customized measures is you cannot benchmark yourself, whereas in standard nationwide measures, you can benchmark your performance. So George, what are some of the potential sources of information we can use with measurement process?
Well, that's an extremely interesting topic, as the possibilities for data to help with both population assessment and management seem to be increasing day by day. At the most summarized level, there are data sets like the County Health Rankings Project and the American Community Survey, These are useful for comparing regions and trending data year to year, but they're not particularly time-sensitive or geographically specific. Now, at the other extreme, we have data at the individual level. That's important for understanding certain health outcomes, but it typically only provides limited visibility into populations. But this data is becoming more comprehensive and more accessible. 3 examples. First, statewide all-payer claims databases, as are available in Massachusetts, Maryland, and Vermont. At the federal level, CMS is making more information from the Medicare and Medicaid programs available for research. And at the statewide and regional level, there are health information exchanges with clinically rich versus claims data and longitudinal views of individuals beginning at birth. Maine's Health InfoNet is a good example of that. And then there's the increasing maturity and adoption of standardized data. That's also helping make clinical information more actionable. We'll talk more about that shortly. Then there's the middle, information that's not specific to individuals that can be linked to specific geographic locations to help isolate communities, neighborhoods, and various cohorts based on socioeconomic factors. Some emerging sources include demographic and social determinant data sets available down to the census tract level. These are becoming available from various sources, including information aggregators such as TransUnion, who are looking at how their information services could be used to promote health, and specialized data sets that provide perspective on availability of food, transportation, and various services, health-related and otherwise, such as community commons. And finally, there's the quickly evolving area of data generated by individuals. 2 examples of this are patient-reported outcomes for health and wellness that help to assess things like physical and behavioral health from the perspective of the individual, and biometric information from wearable devices that can continuously monitor measures of health and wellness. The bottom line is that there's more data to work with, but where's the bang for the buck in this ocean of possibilities? So to help answer that question, let's look at an example of how these information sources can be assembled to help meet the goals of improving the health of populations.
Vermont's approach to population health is one of the most innovative statewide models. In fact, it's been designated by CMS as an official advanced payment model. The implementation combines One Care Vermont, a statewide accountable care organization that includes the state's 3 main insurers, Medicaid, Medicare, Blue Cross Blue Shield of Vermont, with the Blueprint for Health, which designs community-led strategies for improving health and well-being. Among its programs are promoting the patient-centered medical homes model among Vermont's primary care practices, community health teams, a hub-and-spoke systems for treating opioid use disorder, women's health initiative, and outreach for support services at home. Vermont's strategy combines healthcare delivery resources with community-based resources and coordination to achieve their population-wide goal. The goals for Vermont statewide priorities are limit the annual expenditure growth to less than 3.5%, which covers the cost aspect of the triple or quadruple aim, increase access to primary care, which kind of touches on the experience of care, limit the increase in prevalence of targeted chronic conditions, including diabetes, hypertension, and COPD, and reduce death from suicide and overdose.
A critical aspect is information. So to guide the program, Vermont uses data from their statewide all-payer claims database and the Vermont statewide clinical registry, which is populated from electronic health records data from primary care practices. The fidelity and effectiveness of population measurements has improved significantly by combining information from these 2 sources. And Vermont is also actively working to integrate other data sets which would incorporate more social determinants data. These information assets have provided a means to closely monitor the impact of programs, investments, and resources.
George, there's a lot of things going on in the world of technology. Which developments are most likely to affect population health?
There's a lot to choose from, but here are my top 4. First, health data interoperability. New standards such as HL7 FHIR, that's FHIR, are being widely adopted and helping to make the promise of large-scale interoperability of health information a reality. The federal government, led by CMS, the VA, and DoD, are putting regulatory might behind this, but providers, payers, and technology vendors have quickly gotten on board. One byproduct of this is the increasing availability of standardized clinical information, which provides a solid basis for objective and timely analysis and assessment of health outcomes, conditions, and behaviors at the individual level. Then there's the Internet of Healthy Things. That's actually the name of a book that describes how the evolution of remotely connected monitoring tools enables more effective and accessible care models and also allows individuals to participate more directly in their health and wellness. Then there's big data, machine learning, and artificial intelligence. The availability of the data sources we've discussed with their increasing specificity and time sensitivity will only be useful if we can make sense of them in a meaningful context, such as assessing population characteristics. That's what machine learning and artificial intelligence do. They sift out the meaningful signals in a sea of noise. And leaders in this area, including Amazon, Google, and Apple, which all have traditionally had a focus on consumers, are dedicating significant resources to apply their technology to health. And finally, there's genomics and other new frontiers. What we're seeing with genomics and the increasing availability and popularity of DNA testing is likely just the beginning of an information revolution. And there are implications for both individuals and populations, which are hard to ignore. Other examples include microbiomics, the flora and fauna of the digestive tract, and the potential impact of crowdsourcing as applied to physical, behavioral, and community health.
Well, George, that was a lot of ground to cover in 12 minutes.
Yes, it was, and we're looking forward to getting your feedback on how we can continue this discussion around these topics in future opportunities to share knowledge and experience. So please submit your ideas, suggestions, and questions here. So until next time, goodbye.
And be well.